Hi, everyone. My name is Mark Stebbin, and I'm the president of IUSTI Canada, replacing Joanne Dillon, who went to IUSTI World. Today, we have a great webinar, Sex, Stigma, and STIs, Reflections from the book Strange Bedfellows. So we know that STI have been prominent players in our lives for the whole of human history, affecting everything from world wars to reality TV. Yet they are still shrouded in stigma and taboo. So we have today learning objectives of recognizing two myths regarding STI transmission, acquisition that perpetuate STI stigma, analyze media portrayal of STIs that exacerbated existing stigma, and apply knowledge about how STI researchers can use social media to combat STI stigma. And for this lecture, we have the pleasure of receiving Dr. Ina Park. Ina is a great friend, great colleague for many years, and she's an associate professor at University of California, San Francisco School of Medicine. She's also a medical consultant at the Centers for Disease Control and Prevention. She recently served as co-author of the 2020 CDC STD treatment guidelines, and she's a contributor to the Department of Health and Human Services, STI Federal Action Plan. So today we'll have a view of her book that was hailed by the New York Times as joyful and funny. Strange Bedfellows have been praised for its use of compassion, science, and a loving playfulness to diffuse the stigma surrounding STIs. So we'll have a question period after Ina's talk. So Ina, the website is all for you.
Okay, thank you, Mark. And one correction is in between when I submitted my bio to now, I actually became a professor. So that happened. So I'm no longer an associate professor, I'm finally a professor. So I'm gonna put my feet up and stop working. That's what I've decided to do. All right, I'm gonna actually share my screen. Give me 1 second. Can you see that, Mark?
Yes, perfect.
Okay, fantastic. So I have nothing to disclose to the group. And I do apologize. I am located in the United States. And so, you know, my sort of data and the way I frame this talk is around what has been happening here in the US. But the topics of stigma, I think, and shame around STIs are universal. So I just wanted to reflect here where I'm sitting, the state of STIs prior to the pandemic, just to let us know where we are in space and time. So 2019, which is the last year for which we have complete data in the US, was the worst year on record for reported STIs to the CDC. You can see the case counts there with about 1.8 million cases of chlamydia, 600,000 plus cases of gonorrhea, and almost 130,000 cases of syphilis. All of which, of course, are increases, the worst of which being syphilis and congenital syphilis with a almost 300% increase in the past 5 years from the time that this data was published. And then, of course, as in Canada and in much of the world, that many STIs are occurring among young people. In the US, over half of the reported STIs are among folks 15 to 24 years of age. That comes as no surprise, I think, to this crowd. And then, of course, just to put in context how bad syphilis rates are in men who have sex with women and cisgender women compared to men who have sex with men. You can see the comparison here, which shows a nice sort of time trend looking at the rates per 100,000 population with MSM. And so at least now here in North America, we are experiencing syphilis rates among men who have sex with men, which are very similar to those of the early 80s prior to the introduction of the HIV/AIDS epidemic. So we all know that things are bad. And then, of course, we have the pandemic, which is still ongoing, and how it influenced sexual behavior and then subsequently sexually transmitted infections. So this slide is from Katie Renfro, who's one of my colleagues at the US CDC, and actually goes over studies of frequency of sexual behavior during the pandemic. And most of these studies were actually looking at the time period, immediately after shelter in place. So in the sort of second quarter of 2020. And so in the dark teal bars, you'll see that in many places around the world, these are studies in Asia, Europe, and the US, you'll see that a lot of folks reported that they were having less sex. I think people were, sort of overwhelmed and, panic buying toilet paper and too busy to have sex. You'll see that there's a fair number in the medium teal colored bars that didn't report any change in their frequency of sexual behavior. And, you'll see that there's a minority of folks who actually report increasing their sexual behavior. And as we know, some folks use sex as stress relief. And I do think that that happens to a small extent. And then, of course, a lot of chemsex going on as people were self-medicating to cope with the stress and anxiety of the pandemic. So, of course, people's sexual urges didn't go away. And so I'm not sure if folks have seen these statistics yet, but in terms of how folks' sex lives went online. So Tinder actually recorded its highest number of swipes ever on the app with 3 billion swipes on March 29th of 2020. Apps like Bumble and OkCupid also reported a huge increase in video calls and dates, many of which were virtual. And here in the US, we had a substantial shortage in STI testing kits, and that led to a decline in STIs simply by the fact that folks were managing these infections syndromically and not able to do testing. And so in the third quarter of 2020, we had over 65% of labs that were surveyed, and this included large commercial labs as well as public health labs, actually had a shortage of their STI testing supplies. So during this time on Twitter, folks were talking about actually going back to using intraurethral swabs for cisgender men and trans women, as well as just treating syndromically without actually doing testing. Even by the end of 2020, almost half of labs still reported a shortage. And luckily, for the most part, from what I've heard, that these shortages have been remedied. And I would, love to hear as well if this happened in Canada and if it was to the same extent. And so, probably unsurprisingly, STIs plummeted during that second quarter of 2020. And you'll see that both gonorrhea, chlamydia, and syphilis here in the purple, orange, and blue bars went down substantially in April and May of 2020, but you'll see that they began to creep right back up. And so then by the end of 2020, chlamydia was only 14% lower. And as you all know, many public health clinics shut down or reduced their hours during the early days of shelter in place and, or stopped doing screening of asymptomatic folks. Now for gonorrhea, it bounced right back and then, came back even more with a 7% increase compared to the year prior, and primary and secondary syphilis is now essentially unchanged. So this may come as no surprise to folks, especially those of you who work in a sexual health clinic like myself. The waiting rooms are full again, and it seems like people have resumed their, getting back on apps and hooking up. So here in the US, these data were actually just released last week. I did mention earlier that we had a 300% increase in congenital syphilis, and the preliminary numbers for 2020 actually look worse. So there were actually 2,022 congenital syphilis cases, which is the highest we've ever seen since 1994 here in the States, with almost 140 stillbirths and neonatal deaths. And as, by point of comparison, with HIV, perinatal transmission in 2019 here in the States, you'll see that we've nearly eliminated perinatal transmission due to, multiple interventions that can occur even at the 11th hour, which, for congenital syphilis, for those of you who don't know, we don't really have that kind of wiggle room, and treatment should be rendered 30 days prior to delivery to ensure avoiding a case of congenital syphilis. So that's where we are in space and time. And what about 2021? Pre-Delta, I really thought we were going to bounce back with a vengeance. Condom sales were surging. There were lots of ads sort of demonstrating what people were going to be doing after the pandemic, after they got vaccinated. And certainly lots of my patients got right back online as soon as they got vaccinated, and were sort of flexing their vaccination status on their dating profile. And certainly that happened. And, whether or not Delta mitigated that and what's going to happen with STIs in 2021 still remains to be seen. So the crux of my talk and sort of the focus of my work in this phase in my career has really been around STI stigma. In my book, I do talk about some of the roots of STI stigma, in particular, how it manifests for specific STIs. And I want to just take a very brief walk with you, a historical walk with you, to look at the history of STI stigma, which is certainly not complete. And then also analyze how stigma on a personal level can interact with other forces, societal forces, that help sort of reinforce those patterns of feeling around these really, really common infections. So I want to credit the STI Project, and those of you who are on Instagram, I strongly recommend that you follow the STI Project. It is run by Janelle Marie Pierce, who is a woman who is living her life out loud with HSV2, very out and proud about it, and I love her content. But there's many layers to STI stigma, and I think those of us who may interact with people one-on-one will be very familiar with the interpersonal stigma or internalized sexual shame that folks may feel when they receive a diagnosis. But we also need to understand that this occurs in a context of how people relate, what messages they receive from peers and family systems and religious organizations if they practice, all the way down to macro systems such as cultural attitudes and how they play into and feed into people's interpersonal feelings. So going back to biblical times, STIs have often been thought of as God's punishment for quote unquote fornication outside of a male-female heterosexual relationship. And this quote from Hebrews 13:4 is, I think indicative of the sentiment around STIs, that they are a judgment and a punishment for sexual immorality. And even the term venereal disease, which derives from the term venery, would imply that immoral behavior is associated. So I just wanted to go back to World War I. These are posters from the US government that actually use that terminology clean, which a lot of my patients still use to describe their STI status. So you'll see that the clean America, and just to reflect that STIs, in particular gonorrhea and syphilis, were cause of a huge loss of duty during World War I. 7 million person days were lost, with over 10,000 men discharged, pardon the pun, due to syphilis and gonorrhea. And only the 1918 influenza pandemic actually caused a greater loss of duty. But anyway, the framing here really is that keeping America clean and free from STIs is going to sort of help ensure our victory from a military standpoint. So then, of course, Sir William Osler did, I think, a wonderful job of describing syphilis stigma. And essentially, syphilis was so taboo, that family members and even folks who were sort of on their deathbeds due to syphilis, they would actually ask to have a different cause of death sort of recorded as the official cause of death, which leads to an undercounting of infections. And of course, this happened very much during the HIV epidemic as well. And therefore, from a statistical standpoint, it was impossible to tell how much syphilis really that there was, because there was so much stigma associated with the diagnosis. And then meanwhile, moving on to the 30s, there was a huge syphilis epidemic, and syphilis was much more prevalent. The seroprevalence from the US Public Health Service was estimated to be 1 in 10 adults at that time. So the US Surgeon General went on a huge campaign to sort of illuminate the public about syphilis and its existence. So they did over 125 articles in major lay publications throughout the US, even the cover of Time magazine, which, by the way, makes no mention of the word syphilis, but just says that it's taboo and doesn't even mention exactly what the infection is. So again, indicative of the stigma that we can't even say the word syphilis on the cover of a magazine. And I feel like that's probably still the case. I would love to see syphilis on the cover of Time magazine in all its glory right now. By the time we got to World War II, this was the heyday of anti-venereal disease propaganda and shaming and blaming soldiers if they were the ones that were going to lessen our chances of victory by getting a sexually transmitted infection. Again, here's the phrasing, there's no medicine for regret. Here's the language again, she may look clean. And so, the posters and propaganda of the time would say that you're a saboteur, you're gambling with our freedom. And so therefore it is your fault if we lose this war because you got gonorrhea. So this is all framing, right? Already some stigma and shame around this and just adding fuel to the fire. I'm going to fast forward now to the 1980s because I think this is a controversial topic, which is herpes stigma. Online, if you go into social media spaces such as Reddit and as well as on Instagram, there are lots of folks who say that herpes stigma was invented by Burroughs Wellcome, which is now GSK, and that they invented the stigma in order to sell acyclovir. So this is one of the things that I analyze in my book because Larry Corey, who was one of the developers of acyclovir, who also used to see patients, in the 70s prior to the development of acyclovir, was saying that this was preposterous and that herpes stigma for those who had symptomatic disease was awful and certainly predated the development of acyclovir. And back then, the treatment that he had available were things like ether and radiation therapy, which were often worse than the disease itself. But you can see, though, that the language around the advertising was quite stigmatizing, implying that the worst thing you could do is tell your partner that you had herpes. And then, of course, labeling herpes as the scarlet letter. And literally in this article, they mention folks living with HSV as poisoned, unmarriageable, depressed. And so again, didn't invent the stigma, but certainly adding fuel to the fire. And I hate to say it, but herpes stigma is still going strong. So there's actually a book called Bachelor Nation, which is sort of a tell-all of the inner workings of ABC's The Bachelor. But herpes is one of the top reasons that applicants are rejected. The testing done is a serology test, which many of you on this webinar know has very poor specificity, and at low index values probably has a specificity around 50% or less. And so my point is that I think it would do a lot for herpes stigma if they actually allowed somebody with HSV on the show and had the Bachelor actually cope with this, or the Bachelorette for that matter. But at any rate, this is still something that is being used to exclude folks, and again, based on false pretenses, because many of these positive results are false positives. And I've always said that, we need more sex positive advocates for herpes in particular, and other STIs. And unfortunately, the portrayals of STIs when celebrities are sort of associated with them are overwhelmingly negative. I will give you an example from this week, which is the trial of disgraced R&B singer R. Kelly, who, among many other accusations of sexual assault, is also accused of knowingly infecting his partners with HSV. And so, unfortunately, we don't have a lot of folks, unlike HIV, who are living their lives out loud, with HSV, even though we know, of course, there are many celebrities who are living with this virus. And I just want to contrast it, of course, because we know that HIV stigma and AIDS stigma was incredibly prevalent in the 1980s, called the plague, and folks who were men who have sex with men were being harassed, assaulted, etc. But I feel like we've come so much further with HIV than we've been able to come with STIs. And in speaking with my patients who are living with HIV, especially those who are cisgender women who sleep with men, they still feel stigmatized. Disclosure is still very difficult, but the fact that we have U equals U, and for those of you who are not familiar, if folks are taking HIV antiretrovirals and they're virally suppressed, then they're not able to transmit the virus sexually, which is a result of the partners study, multiple randomized trials actually with hundreds of thousands of unprotected sex acts. So we don't have a U equals U for HSV, for example. And I think if we did, that could go a long way in reducing the stigma around this infection. So I just wanted to talk about some of the concepts in my book that I think are myths that are widely held out there about STIs that perpetuate stigma. And now that I've been spending more time on social media, I can just attest that these myths are alive and well. And the first is something that I think we would call slut shaming, and the myth that STIs result from promiscuity, when, I think many of us know that the prevalence of an STI in the sexual network and concurrency of partners is as important or more important. And I think one thing that has been interesting for me now that I've been talking to lots of folks who are outside of our field around this concept is a lack of understanding of how sexual networks work, and that even folks who report monogamy can have very different levels of risk depending on what type of networks their partners are in. And so one of the things I've been explaining a lot when I've been doing media is when people have a strong preference for partners of a specific race or gender identity, if the networks are very tightly knit with very few degrees of separation between folks, then the ability to transmit STIs quickly in a network and the risk, even with a small number of partners, can certainly go up. And another thing I've been explaining to folks a lot is how serial monogamy, even if someone has many partners, especially if they test in between partners, can be lower risk than something like concurrency. And I think people think a lot about the absolute number of partners and don't think enough about the way people connect in space and time, and how concurrency with the same number of partners versus serial monogamy elevates the risk of HIV or STI transmission. And one of the examples that I use is this example here around HIV transmission. And when you have people who are sharing, and having concurrent partners, the proportion that have concurrent partners doesn't have to increase by much to increase the connectedness of the network, and therefore increase the risk of HIV should it enter the network. So these are the ways that I'm trying to sort of untell the sort of common understanding around STIs as a result of promiscuity, and framing it more around how people connect, and framing it more about sexual networks. So the other myth that I feel like really feeds stigma is around racial disparities, because anytime there is a presentation around STI disparities, you will hear that people of color are, have higher prevalence or higher incidence of STIs. I think we're doing a disservice if we don't talk about how structural racism feeds into these disparities. And, lots of folks have done research on this, including Sebke et al. From the CDC, Michelle Andrasik from University of Washington. And one of the things, going on here with structural racism and mass incarceration, for example, is that, for Black cis women who like to have sex with men, some of them have very strong preferences to only have sex with Black men. And if men are removed from the community due to violence or mass incarceration, there is a distortion of sex ratios in some communities, which leads to literally not enough heterosexual men to go around for all the heterosexual women that want to be sexually active. And so therefore, there are higher rates of STIs and HIV for Black women, even though, at least in the US, rates of condom use and number of partners is similar to that of white women. And so I think if just disparities are presented without any context around them, it can lead folks to think that there are different sexual norms or different sexual behaviors, among Black women compared to white women, for example, or other women of other races. So this is another myth that I'm sort of undoing when I'm, talking to folks about STIs who are not familiar as we are. So in this phase, this is sort of the last portion of my talk, and I'm just going to share a little bit about my journey around what I'm doing to undo the stigma, and I hope to encourage some of you who are researchers in the field or clinicians in the field to do the same. It is difficult because it is time consuming on top of what we are already doing, but I have to say that it's been very rewarding to be able to connect with folks on social media and start to undo some of these teachings that incorrect teachings that many of us have received. So one of the things around public engagement, even if you end up joining Twitter or Instagram or one of these platforms, you don't necessarily have to post very much yourself, but you can speak out when you see negative behavior or statements. You can also, retweet or amplify the posts of other people that you like. And there are many people on social media who just do that. They don't actually post their own content, but they just amplify the content of others who they support. And that can include, correcting negative language, and you can create your own content and share information. And if you do that, to use a diversity of images to show that STIs can affect anyone and not just certain populations. And I'll give you an example because somebody sent me a piece they were working on, a video around sexual health. Every image in the video was of a cisgender man and woman. And I said, you have to change this. That's not inclusive. That's not necessarily stigmatizing around STIs, but you cannot just talk about sexual health and only show, one type of community. So, again, trying to diversify and include, non-binary or other gender diverse folks in our images as well, and not just cisgender folks. Normalizing STIs and accurately communicating risk. So that is one of the things that I'm really passionate about right now, is just telling everybody that everyone gets STIs every time I have an opportunity to do so with a journalist or some sort of media outlet. I normalize STIs and just talk about how universal they are, in particular the viruses such as herpes or HPV. And then I'm going to talk a little bit about how you can engage with media channels if you want to do your own work around combating the stigma. So here's just some examples about speaking out against shame and harmful language. These are, just two tweets that I pulled, one of whom is a colleague over here on the right, Ariel Watrous, where she's trying to sort of unteach people from saying the word clean around their STI status. I also wanted to share, because there are some folks on this webinar like Caroline Cameron and Celia Braithwaite who were instrumental in this campaign, a social media campaign called Face of an STI, or Stop Stop Stigma, which was born out of a conversation between Emma Harding-Esch and Jackie Cassell. I was on Twitter instead of probably doing what I should have been doing, which is probably answering emails or doing other work. But I, saw this would be great. Why don't those of us in the community who are sort of out and proud about being associated with STIs to go out and do a Twitter campaign? So the National Coalition of STD Directors, Amanda Dennison, as well as the company Giant Microbes, who makes all those cute stuffed STIs, got on board along with the STD Journal and Wolters Kluwer, their publisher. So we, at the ISSTDR meeting, which Caroline and Charlotte Gatos were the chairs of, we set up a photo booth and had folks from all around the world come and take pictures, and we posted them under the hashtag Face of an STI. We were trending briefly on Twitter for a while, and so we had over 370,000 Twitter impressions, with over 79,000 Twitter users were reached with the hashtag and saw at least one of these photos. Switching to another platform, which is Reddit, I just wanted folks to know that people are crowdsourcing diagnoses and advice. And this is from JAMA, demonstrating the number of requests for an STI diagnosis, including pictures, on a social media platform under the subreddit or subheading RSTD. And so a researcher and I, Christine Johnston, who studies herpes, primarily herpes shedding, got on Reddit and actually, said, hey, we study STIs, ask us anything. And we couldn't even answer all the questions. We got over 300 questions in an hour. And so my point is that these platforms, there are people hungry to hear from you. If you are interested in getting on and sharing your knowledge with folks, you will find a very hungry audience for this. One of the things that I've also done is recently I've gotten on Instagram. I just have a few posts right now, about 28 posts. And I'm just trying to put out positive and accurate content around STIs, around testing, around different organisms in particular. And another thing that I've decided to do is partner with folks that are more influential. So this is Shan Boudram, who now has 500,000 followers on Instagram. So we decided to partner to do a video on U=U. And, because of her reach, it has over 200,000 views. And so this is a way as well, to partner with people who have more clout than you do, to reach people with this content that is hopefully destigmatizing, around HIV. The other thing that I would encourage you to do, even though I know it is very difficult and painful sometimes, is engaging with journalists. These are some of the pieces that I gave quotes for. One of which, you don't get a lot of say over the title of the piece. And you can see the title for this BuzzFeed piece was "Experts Predict a Slutty Summer," which is never a term that I would use. You don't often get to see the piece before it runs or actually approve your quotes. But honestly, I have never been misquoted in a publication so far. So I have not been burned yet. When I've said things are off the record, people have kept things off the record. I think if you're very clear, this can be a way, though, to get the right information out to a much larger audience. And again, you can offer those anti-stigma messages while you're giving out the facts, which is what I try to do. The other thing that I would encourage folks to do is that, if you feel passionate about a topic within the field of STI, to write an opinion piece for the lay press. The OpEd Project is online, and they do lots of courses, of course, about how to write an op-ed. but this can be a very effective way to share your idea with a broad general readership. And when I did a fellowship on public engagement, and this was a huge piece of the fellowship, was how to write an op-ed, and what there's a formula to it. But the OpEd Project actually has free resources. And if you have a group of people at your university, like our university has had this project come and actually had researchers come and have a 1 day or a half day course on writing opinion pieces. And their sort of motto is whoever tells the story writes history. Because again, we can talk to each other and we are all, I feel like, of one mind in terms of how we feel, but getting our ideas out to the larger public is the next step, I feel like, in terms of reducing stigma. And I am here to say that you can do it. I am living proof. I had never written an op-ed ever until, about a year ago. And the New York Times piece, I sent them 2 other pieces, which they rejected. This piece by Stat News, which is run from the Boston Globe, rejected from 5 publications. And our communications person at my university actually shopped it around to lots of publications. So I did not spend all the time doing this myself. And then this piece in Scientific American came about because somebody read a different piece and reached out to me. So I did not get rejected from this, but we are also used to rejection from grants and writing manuscripts, that it's just another rejection, and it doesn't hurt any worse than the rejections that we're already used to. Or if you really want to go nuts, you can write a book. I don't know if I'll be able to do it again. I mean, it's really difficult. It was really difficult to fit it in terms of doing it on the nights and the weekends and putting it in my regular life and ignoring my family when I had deadlines and whatnot. But this is a love letter to all of you who do this work. I mean, I love this field so much. It's got the most incredible people, and that's why I wanted to, write this book. Yeah, so I'm not sure I'll do it again. I'm thinking about it, but I would really start with a short form piece, such as an op-ed first, before you embark on doing such a big project. But if any of you actually feel inspired and moved to want to do this, I want you to reach out to me, because I have resources. I've actually compiled them and I can email them to you about how to get started with the process. It's just like writing a grant. You write a proposal and you shop it around to agents. And so I have a little how-to, and I'm actually very happy to meet with folks one-on-one if they do want to try to publish a book with a traditional publisher. And meanwhile, I just want to say that in this process, I've had to become educated around topics that are adjacent to STIs. And I just wanted to share with folks some of the resources that I have discovered in my sort of process of disseminating my work in a more public space. So one is, people often ask me, is there kid appropriate content on STDs that you feel like is accurate? And amaze.org has great cartoons on defining STDs, HIV, PrEP. I feel like they're appropriate for school age kids if you want to get their education going at an early age, which I do recommend. There's also messaging about how to talk about sex with your kids. This is the most common question that I get asked, I think. And talkwithyourkids.org has a PDF that talks about the different sort of ages. And there's a PDF that actually has messages and puts the words right in your mouth if you don't know exactly what to say. For those of you who are not aware of tellyourpartner.org, it's anonymous STI partner notification, which is run by the Building Healthy Online Communities group. And then for those of you who see patients who are recently diagnosed, Courtney Brame is an African-American man who is living with HSV and started a wonderful podcast called Something Positive for Positive People. And it just goes into all of the different questions and feelings that people have when they receive a herpes diagnosis. And it just delivers a lot of the content that you may not have time to counsel about in the office. So, again, especially if you want some advice about writing a book, and if anybody has, if people want me to talk about that process in the Q&A, I can definitely talk about it in a, in a short form. Please reach out to me via email, and here are the other ways to get a hold of me, and my social media, which is, still a work in progress. But I'm going to actually stop sharing and go look at the Q&A and the chat.
Great. You gave a very good presentation, Professor Park. So thank you. Just for people, just to let you know, you can answer your questions in the Q&A box, or you can lift your hand on the computer. So just to let you know, there's something in the discussion pane about the microbes, the giant microbes.
Oh, sure.
Interest as Christmas is coming, maybe you would like to
absolutely
have a giant microbe. So thank you for the person who posted.
Yes, please. They make fantastic Christmas presents. I have the entire collection, including the giant ones that are 2 feet big across. So there's this question from one of the attendees specifically around HIV rates among African-American men. And, the question was around how incarceration may affect that. So incarceration of heterosexual Black men can influence rates of HIV among Black women because of higher rates of concurrent relationships. So meaning, one man is having sex with multiple women, and therefore can, if HIV is present, can then be transmitted more quickly in the community. So there are huge disparities, as folks know, with HIV among Black women. And part of that is around not having higher rates of concurrent relationships for Black men. Now, if we talk about HIV among Black men, and especially if we're talking about, men who have sex with men, whether they identify as gay or bisexual or not, there it has to do a lot with sexual networks. So especially if gay Black men prefer to seek partners that are also other gay Black men, the networks are much smaller than, for example, the universe of white gay men. And so therefore, the degrees of separation between folks in a sexual network are often smaller. And if an HIV enters a network, it can spread more quickly. So then, of course, all of the things we talked about around stigma and lack of healthcare seeking and discrimination and racism can also feed into the fact why folks may not be virally suppressed, why they might be more likely to transmit. So there's obviously multiple factors that go into why there are disparities for Black women as well as for Black men. Let's go, let me look in the chat. Is there more?
Yeah, there's a question about missing a part of the presentation. There will be a link that will be sent, and the recording of the webinar will be available on IUSTI Canada website. So for those who have missed or would like to pass it to a colleague or listen again, so this will be sent automatically. You'll have the link. There's a question about any advice for folks diagnosed with HSV-2 who want to enjoy their sex lives again. Anxiety about passing it on seems to have a big impact.
Yeah, I mean, I have to say that some of my patients who have been newly diagnosed, even if they don't know whether or not they're going to be someone who has recurrent outbreaks, have chosen to go on antiviral suppression right away, especially for the first few years, that those are the years where viral shedding is most common. For some people, that has reduced the anxiety around having sex, because at least they know they are doing everything that they can to, sort of to protect themselves. The other thing is that it often takes time. I think in the immediate post-diagnosis period, many people are just trying to figure out how they're going to navigate their sex lives. They're trying to figure out how they're going to disclose. So, it can take time. I've had patients who have had therapy for it, and I have had patients who have just sort of shrugged it off, and it's not been a huge deal for them. So I think the range of people's responses is very broad. And I have to say, I do tell people to actually go on social media and look at the content for folks who are there. There's lots of people living with HIV who are sharing what they do and their tips and tricks around navigating their sex life, as well as that podcast that I told you about earlier. But again, it takes time. And for some folks, it is not easy.
If I may just take a second to talk, at the end, we'll talk a little bit about the project from CPHA. And there's a case where we discuss about stigma reduction and in a person who has been diagnosed with herpes, also with HIV and anal cancer and hepatitis C. So at the end, we'll share the link to this CPHA project. And for those who want to go on the Public Health Agency of Canada, there's a counseling tool that was done because of Hunter Hansfield in the United States. You received so many questions about people in Canada having problem accessing counseling. So we did something, Bill Fisher and myself. Bill is a psychologist in STI for at least 35 years. So there's a counseling tool that is there on the Public Health Agency of Canada website. So you can look genital herpes counseling tool, Public Health Agency of Canada.
Yeah, I mean, I think honestly, the medical care of STIs, is something that is less complex than trying to figure out how to help people cope with the stigma, and trying to undo that on a societal level is a much bigger lift. And yeah, I would love for all of you to engage in that. We need more folks who are doing that work. So I'm really happy that CPHA is putting out these learning modules. I think it could be really helpful as well for people in training.
If I may, Ina,
yes,
I frequently hear about people feeling very, very careful about posting something against an advice that is negative, to be identified and then to be crushed. We had colleagues who were really swamped with response on, I thought was very correct comments about social media. Do you feel that would be a reason why we should not engage in social media, or maybe it's better to know the best practices on interacting on social media?
Yeah, I mean, I think it's always a risk when you put yourself out there. There are also people who are trolls, we call it like trolls online, who I've posted content around, sex positivity and sex education for, for children, for example, in schools, and then, had people come and insult my parenting. And so I think there is always that risk. But I have to say that overall, my interactions on social media have been overwhelmingly positive, and that people have generally been welcoming of the information. I do think that, there is always a risk, And I wish I don't have a great resource for like what are Twitter best practices or whatnot. But certainly, you know, if I learn of something, I'll share it with folks, but I'm not sure. I don't think that should prevent you from getting on those platforms though, because really they can be also wonderful spaces to learn about new research. That is one of the ways that I use, I think, Twitter most often, is just to hear about new data in the field, new tests that are developed. Often people will share them on social media, and it's a great way to stay up to date.
We have a question. How do you think we can achieve a groundswell of activism for STI like we saw for HIV in the 90s from the public, to get more research dollars invested, more awareness from the public, lessen the stigma?
Yeah, I mean, I think one of the ways in that I think, you know, I've been thinking about is around congenital syphilis. I don't know, like here in the US, it's just one of the things that I've been thinking about in terms of nobody can blame a baby or a child, you know what I mean, for being born with syphilis or having a stillbirth due to syphilis. And so I think one of the ways that I've been thinking about is trying to get people mobilized around prevention of congenital syphilis. I think around HIV, a lot of folks felt that gay men who were becoming infected with HIV were sort of getting what they deserved or whatnot. But I think in the US, at least when Ryan White, who was a hemophiliac who had HIV, was a child, I think that began a sort of groundswell of more public support around it. And I'm, you know, not that I want to capitalize on the tragedy of congenital syphilis, but it is, I feel like, one thing that a lot of people can sort of agree on, and that the victim is blameless, you know, in this situation. So I would also love to see, as part of the HHS in the United States, the Federal Action Plan, you know, there is a call for, greater public awareness and campaigns around this. Now, whether or not the government will actually act on that, especially given COVID going on, you know, we'll have to see. But I don't have the answer to that question, unfortunately, but I'm working on it.
There's a question also. During this pandemic, another layer of stigma was added, and it was breaking public health recommendation of isolation to have sex with anonymous sexual partners. So layers of stigma and intersection, indigenous peoples, people who use drugs, person living with HIV, how to better approach these multi-layer stigma.
Yeah, I mean, I think that there's greater recognition, and we were talking about it actually before this webinar, of the intersectionality, right, of multiple factors and why people might be experiencing stigma on multiple levels. I think that there's a general, at least in the medical community, a general lack of awareness around intersectionality. And I feel like we could do a lot to just increase folks' awareness, because then I think that they're less likely to use language or, you know, to treat people in a way that worsens their stigma or makes them less likely to come to care. So I think that there's got to be an acknowledgement and a deeper understanding of intersectionality in general.
Thank you very much for this presentation. Canada is also seeing an increase of congenital syphilis in recent years as female cases have increased. How can we explain the increase of certain STIs in female versus males?
I mean, I'm not sure how the epidemic is playing out in Canada. The explanation for it in the US has to do a lot with the crystal methamphetamine epidemic as well. At least in my part of the country, a third or more of the cases of syphilis in women are occurring in folks that are, again, with intersectionality, right, who are using crystal meth. And so I think, you know, as the earlier questioner had pointed out, we need to understand the intersecting epidemics that might be feeding in. So it's not just racism that's feeding in, but it's also substance use or whatever, because I think then it allows us in public health to actually try to integrate our efforts alongside other programs. We often work in these silos, I think, in public health, like, this is our program, this is your program, but there has to be greater integration and discussion, I think, across areas of public health because of the intersectionality of different epidemics, if we want to, attack this problem and actually have good results. But at any rate, I'm not sure how it is in Canada, but certainly substance use is a huge issue for us here in the US.
A last question, does stigma impact women more heavily for certain STIs, resulting in less testing?
Can you repeat that question again?
It's not there anymore, it's in the resolve one. So
okay.
Does stigma impact women more heavily for certain STI, resulting in less testing?
Yeah, I think there's overall stigma of just being diagnosed with anything, and that prevents, I think, people from going in and getting tested in the first place. So I think a way around that is to routinize testing, to say, just like you go to the dentist every 6 months, to say, okay, I'm doing STI testing every 6 months. That's part of my routine. I think that's one way around it. A lot of the online ordering platforms, telehealth platforms, which are offering at-home STI testing, Charlotte, who I think is on this webinar, has done that for many years. I think that can also help reduce the stigma. But then I think that I don't think that this is universal to women, but I think there are certainly, STIs such as herpes carry with it a much greater stigma than something like gonorrhea, which can be treated with a single dose of antibiotics. So there is a hierarchy of stigma, I think, with STIs. I think with herpes being on the top, and actually I think higher than HIV, believe it or not, in some circumstances. And HPV also, there's a lot of stigma around HPV, even though it's sort of a universal infection, as Mark knows. It's surprising to me how much stigma there is around that. With the bacterial STIs, many of my patients say, they blow it off. They're like, oh, I have gonorrhea again, not a big deal. So I'm happy that they are not stigmatized by it, and as long as we can normalize and routinize being tested frequently, so that we can catch infections early.
Yeah, maybe there's a portion of the program by CPHA that is interesting. It's about trauma-free medical care. I think some people are brutalized in our healthcare systems and don't feel well received, so they refrain from seeking care.
Can I make a point on that, Mark? I think CDC had just released a new guide to taking a sexual history when they released their guidelines, and a trauma-informed approach, I think, is really important because so many people have had sexual trauma or a history of abuse. And there was a lovely GUM doctor from the UK who had posted on Twitter, one of the things they do in their clinic is if they notice someone is becoming, upset or triggered by the sexual history, they actually just hand them a rectal swab, a pharyngeal swab, a vaginal swab or a urine cup, and they say, test whatever you want us to test today. And they don't even, they don't go into great detail about what went in where and how many people and gender of partners. I think that's ideal if people, are willing to share that. But I think taking a trauma-informed approach for someone who has an abuse history or doesn't want to disclose that information can be saying, here's the menu and you order what you want.
So thank you very much, Professor Park. Looking forward to meeting you again. Just before we finish, I just want to acknowledge my colleagues on the executive of IUSTI Canada. VP is Caroline Cameron. She was ISSTDR president before. Secretary Bradley Stoner, past president Joanne Dillon, member at large Irene Martin, and Greg Penny organized also this webinar. Greg is always great to support our IUSTI Canada activities. So Greg, can you put the last two slides?
So yeah, let me just hit presentation mode here, Mark. Do you want to speak to them or do you want me to speak to them?
Yeah, take time, Greg, please.
Okay. So the first thing, and this ties, I think, very well into everything Dr. Park just spoke about and a lot of your questions. So we at CPHA have just launched a brand new course last week, actually, that is for those, it's for everyone essentially, but if you are a physician or working as a clinician, it does have main pro credits, and it does focus on this idea of stigma reduction using case-based scenarios. And as Mark mentioned, it covers a number of different sexually transmitted and bloodborne infections. So I think it's free to take. Please take a look at it. If you can promote it to colleagues, that'd be great. Learning.cpha.ca will get you to the site and you can register and go from there. And finally, we just wanted to let you know that the next webinar is coming up on Monday, October 25th at 10 a.m. Eastern. We will be sending out a link for you to register for if you participated. And as mentioned earlier, we will also be sending out a link to the video for this meeting. So that's everything from me on my side.
Thank you very much all for being there. Thank you, Professor Park, and looking forward seeing every one of you soon for either a webinar or a live meeting at some point in the future. So thank you very much. Bye all.
Bye everyone, thank you.